of marital status is eligible for contraception use, including information, education, and counseling. So when we talk about contraception, we think about how people are using contraception, how people are accessing contraception. So globally right now, around 214 million reproductive aged women do not have access to that reliable contraception. Then some family planning methods, such as condom, prevents the transmission of sexually transmitted disease like HIV, hepatitis, and others. So why are we having these unmet needs for almost 214 million women with the reproductive age? The first problem that we are having is limited choice of the methods. The second is limited access to contraception, especially for young people and the poor, and also unmarried people due to the stigma or the lack of information. Then the third one is fear of all experience of the side effects. Some people have already experienced the side effects and they don't want to use the contraception anymore. The fourth one, there's cultural and religious opposition. While you find that some religions are promoting the natural family planning, others are just even telling people not to use family planning. So then there is poor quality of available services. Well, the healthcare providers are not providing the healthcare as it is supposed to be done ethically and with respect to the people that are going there to look for contraception. So the users and providers biases and gender-based barriers is also a common barrier to the unmet need of all these women. So when we come to Rwanda, we can't go to talk about other places else while we are leaving Rwanda behind. So let's talk about our situation. So when we talk about Rwanda, we have the fertility preference of women of this reproductive age. We can see that women of reproductive age desire to having children. More than 50% wants to have, no more to have babies. So only 10% of married women wants to have a child soon. So another 10% is having another baby very soon, right after delivery. Then others have planned to have the babies later. So what's the problem now with the contraception use in the past years? In Rwanda, we could see that women aged from 15 to 49 years have, in 2000, were taking any methods, 13%. But when you look at 2020 now, the recent Rwanda Demographic Health Survey, we are seeing that 64% are now using any method, contrary to 58% now that are taking any modern method, which include the hormonal methods and barrier methods. So what are the unmet now in Rwanda specifically? So in 2000, we used to have 36, that is the number that was of percentage of women that are married between 15 to 49 with unmet needs of family planning. Then we had now 14%, which is also still unacceptable because it's still high compared to what female clients needs. So for the fertility now, if you compare the unmet needs and the fertility, you can see that birth per women for The 3-year period before the survey of 2020 was 4.1 per women, which means women in reproductive age in Rwanda have the fertility rate of can have 4 children average. So when you look at the fertility trends area of residency, you see that rural person have tendency to have more babies than urban person. Well, right now we are having 4.5 per women in rural place and 3.4 per woman in urban places. So when we go to trends in childhood mortality, we are seeing that right now in this year we are having 45 under 5 mortality and 35 for the infant mortality, and the neonatal mortality is 19 out of 1,000 deliveries. So why are we talking about the trends in family planning? Why are we talking about the fertility trends in the area of residence or the fertility trends in the whole country? And why are we talking about this newborn or childhood mortality? This is in relation also of the planning of the having birth. So we can see that everything is related, from the number desired by the women, also the fertility rate, also the number of children they're having, also the number of children that are dying under 5 years. You can see if there is no spacing, if there is no birth control, a woman can have a child like every year. So which means they are going to have babies under 5, they can be 3 in the house, and taking care of them will be also very difficult. Also, having a number of babies that a woman or a family cannot take care of is also a limitation for a healthy and well-being of the family. So all these are related to also the birth control, the family planning we're talking about, the cost of use, because here, if you see, the trends is showing that pregnant married women also are the ones that have access easily to the family planning. And if we go back to see the fertility rate, we are seeing that it's 4.3 in rural place, which means also the adolescent pregnancy is also high, which contributes also on the fertility rate on the per women in this country. So if there is no contraception, we are having early and unplanned pregnancy, we are having no spacing, we are having under 5 years childhood mortality. And also, lastly, we are having also the contribution on maternal mortality ratio, which we're still having of 203. So imagine if a woman had a cesarean section in the last 6 months and she gets pregnant immediately, she may face uterine rupture, she may face abortion, she may face other complications related to an early pregnancy. So all this we are talking about are related to the use of contraception. So what are the modern contraceptive methods? I'm sure that most of us are healthcare professionals. We are aware of the types of contraceptive methods we are having. So we have short acting, we have also long acting, which are reversible, but also we are having the long acting that are not reversible. For the short acting, we have barrier methods, which includes condom, male and female. We have diaphragm, we have cervical cap, spermicidals, oral contraceptive pills, which has the progesterone-only pills, the combined oral contraception, injectables, which commonly we have now Depo-Provera and Ciana. Lactational amenorrhea is also short-acting, but it's not hormonal as such. So the long-acting reversible contraceptive, the implants, intrauterine systems, or device, permanent family planning methods, including bilateral tubal ligation and vasectomy, but also we are having emergency contraception, which includes emergency contraceptive pills. So today we are going to focus only on barrier method and also on hormonal methods. In general, contraceptive works in one way. It works in providing a negative mechanism of hormonal contraceptive for preventing the pregnancy. How does it work? We normally in woman's body, we have a normal process from the brain in the anterior pituitary. Well, there is a production of gonadotropin hormone. This gonadotropin hormone, they are here, they release, they are located in anterior pituitary. There is a first process of media preoptic nucleus, then stimulating the hypothalamus. Then when the hypothalamus is stimulated, the gonadotropin releasing hormone is stimulated to get the release of the luteinizing hormone, which works immediately on the preparation of the uterus. Then we also have the release of the follicular stimulating hormone, which works immediately right here on the ovary for stimulating the follicle to grow. So when this is the positive feedback, we start by the releasing of the media preoptic nucleus, then which is also stimulating. Then the second one is the release of these hormones. Then the gonadotropin, which provokes the release of the LH and FSH, the LH that is going to work here on the uterus for the lining of the uterus. Then the third process is when the ovary is being worked on for the follicle stimulation. So, and after that, when there is a follicular stimulation hormone, there is also the release of estrogen and progesterone. What happens when we are giving hormonal contraceptive? So this pathway from the media preoptic nucleus to the ovaries to the uterus is called a positive feedback. So when we are giving hormonal contraception, what does this hormonal contraception does? Is that either we are giving the combined estrogen and progesterone, or we are giving progesterone only, or we are giving estrogen. But estrogen, you have to be very, very careful, because at the end of the day, they can cause so many problems when they are given alone. So, for the people who are a little bit mature, you know that, sorry, we used to have pills called lofeminal that they removed because they were causing, they were believed to be to cause the uterine cancer. So when we come back to our, when we come back to our negative feedback, the normal positive feedback comes and make the ovary produce the estrogen and the progesterone. But when we are giving the estrogen and the progesterone here, that means when you are giving hormonal contraceptive, what they do is to go and make sure that they come to stop the stimulation of the media preoptic nucleus, so that there is a stop here. There is no stimulation of the hypothalamus to release the gonadotropin hormone, which means without the releasing of the gonadotropin hormone, there will be no LH, there will be no FSH, which means there's no follicle that's going to be stimulated to maturate. Then there will never be the preparation of the uterus for lining here, which means no ovulation, no preparation of the uterus. That's how the hormonal methods works. So the advantages of hormonal contraceptive methods, we have seen that they work on the physiology, the normal physiology that we have normally from the releasing in the hypothalamus. So they reduce also the risk of ovarian endometrial cancer. They also functional ovarian cysts. They reduce these risks and reduce the risk of ectopic pregnancy, symptomatic PIDs, and they improve the menstrual problems and also some gynecologic conditions. And they make sure that with stopping of the releasing of gonadotropin hormone, all these risks are really reduced. Let's go specifically for the combined oral contraceptive. Well, you are going to be able to be shared all these slides. You can watch on yourself the YouTube video. So for the combined, the combined oral contraceptive are the preparations there of synthetic estrogen and progesterone, which are highly effective in preventing pregnancy. So they contain the hormone similar to human female sex hormone, and they are used by women to prevent pregnancy. In Rwanda here, we have mini dose, a low dose, and commonly we see on the market the microgynon. So the content and the phases and dose and pills per pack per types of COC. So we have combination of two hormones, estrogen and progesterone as a content. For the phases, we have monophasic, biphasic, and triphasic. For the dose, we have low dose that are mostly common, 30 to 35 microgram of estrogen or less. Then we have high dose of 50 microgram of estrogen. So pills per pack, we have 21 all active and 7 break between packs. Then we have one of 28 packs that also have, we have 28 packs that have 7 inactive. Then we will have 28 with inactive, so no break between the packs. So all this, if you go to the pharmacy, this is what you are going to find. So the oral contraceptive packs are always a combination. So most methods, they have estrogen of 30 microgram, then progesterone, they will be having an progesterone of 300 microgram. They are called Malady. So these ones are not really common. So mostly you can find them in pharmacies like Vine or Pharmacie Conseil or Theta Pharmacy. So then we have ethinyl estradiol of 30 microgram with levonorgestrel of 150. They are called Ovrar L. Then there's ethinyl estradiol of 30. There's levonorgestrel of 150. They are called desonorgestrel. Okay. Sorry, I'm experiencing. Okay. So how do they work? So it suppresses hormone responsible for ovulation while stopping the gonadotropin releasing hormone, and also they thicken cervical mucus to block the sperms. So who can use? Almost every woman is allowed to have the COCs, and safely and effectively, including women who smoke cigarettes, if under 35 years old, have an anemia on her or in the past, have varicose vein, and are infected with HIV. So there is a WHO category for COCs use. There is a first category where we have from menarche to 39 years old, endometriosis, endometrial and ovarian cancer, uterine fibrosis, family history of breast cancer, varicose vein, irregular heavy and prolonged bleeding, anemia, STD, hepatitis, and chronic carrier. So these ones, if they have this condition, they cannot use. So for the category, the women under 40 years, breastfeeding under 6 months, also they cannot use, they are in categories. So all these categories are the categories that you can find on Make Will of WHO that we are using to select or to look at the eligibility of women that are using contraceptive methods. So if we look at HIV, you can see that HIV infected, they are in category 1, they are in green, and the antiretroviral, they are 2. So when they are using ritonavir boosted pills, they are in category 3. So if you have a woman who is HIV positive, please use the Make Will and make sure that she's eligible for taking all those contraceptive pills. So as we talked about, is the women, for them to select using the pills, you have to make sure that the Make Will is showing them you the eligibility and you can be able to explain. So after that, I want us to see how to manage the missing pill, because this is the common issue that we are facing all the time. When women come and like, oh, I was on pills, then I forgot to take one. What should I do? I forgot to take two. What should I do? And maybe I completely forgot 3 pills. What should I do? So how to tell the woman who missed the pill? The key instructions are you take a missed hormonal pill as soon as you can, because you know that action time for the pills is 24 hours. So if you have 24 hours and you miss the pill, that means as soon as you remember, you take that pill. If that one pill, then keep taking the pill as usual, and each day the woman may take 2 pills at the same time on the same day. When the missed 1 or 2 pills, started new pack 1 or 2 days late. So take a hormonal pill as soon as possible, then there is little risk or no risk for pregnancy. When a woman missed 3 pills now, more than 3 pills or 3 pills, they have to take a hormonal pill as soon as possible, use backup method for the next 7 days, and also if she had sex in the past 5 days, she can consider emergency contraceptive pills. Then when she misses 3 or more pills in the 3rd week, here is in the 1st and 2nd week of taking the pills. So you ask her to take the hormonal pill as soon as possible, finish all the hormonal pills in the pack, throw away the 7 non-hormonal pills in the 28 pack, and start a new pack the next day. So commonly, women come to us and say, oh, I've forgotten 1 pill, I've forgotten 2 pills. What should I do? This is the way you tell them, but you have to figure out which week they have used during the missed, like during which week they have missed the pill. So before moving to the other methods, if there is any question on pills, we can talk about it right now. And I can accept some questions. Then some can be put in a chat and others can be given a flow before we move to progesterone injectable contraceptive methods. Hello, the floor is yours. You can ask me any question.
Hello.
Yes, please.
My name is Joseph, and I really appreciate this interesting presentation about contraceptives methods. And I want to ask you about those periods. As you said before, they stop stimulation for production of RH and HSH hormones in women when they are taken. And asking myself if these periods are taken a longer time, like 5 years, like they're active in the women body for 5 years and more, cannot stop completely these glands to function. Because I refer to theory says that if, for example, the body is not active at the moment, at the time we start to use it, they cannot work properly. Not only the organ, even in the natural ways, if something is not active, it should sleep forever. What the science says that, how the science says that. Thank you.
Thank you so much, Joseph. Actually, the way the pills work, it's not only the pills, it's all the hormonal contraceptive methods. They work in a way of suppressing the stimulation of gonadotrophin hormone to be released. When they are released, as I explained, they are also stimulating the release of LH and FSH, which also acts one on the uterus for lining, another one for the follicle stimulation, and also stimulating the ovary to release estrogen and progesterone. So I totally understand your concern, but the physiologically and a lot of research have been made on the contraceptive use. So if the suppression is stopped, it doesn't mean that it's stopping completely the organ to function. So if they were not safe, they could not be released on the world for the women to use. So scientists and those ones who have been conducting research on the use of contraception have seen that it doesn't have any effect on the long time as you're afraid of. That's why there is also a return to fertility for those women who have been using contraceptive for a long time. An example is those who are using like Mirena, implants, and others. They have return to fertility that is immediate or can take a little bit time because of the body to be adapted to the new change that now there is no other contraception. Otherwise, if there was that concern, the contraceptive could not be released used in a safe way for. So I think more with these PowerPoints, I can share with you the new research that have been conducted on the use of contraceptive and the reaction of the body for women.
All right.
I will take
Yvonne, thank you very much.
one other question, then we continue.
Sure.
Any other question?
So we have another question from Bonaventure.
Yes.
He was asking,
yes.
You talked about art and COS. I don't know the meaning. What's the interaction between those two?
Yeah, it's contraceptive all combined and also antiretroviral drugs. So I've talked about it, but there are specific drugs because one makes another one be inactive. So, which means when you are taking oral contraceptive pills, I can go back on the slides and show you. When you are talking specifically like ritonavir and others, they have to look at the regimen where you are so that you can be able to use the oral contraceptive. So what happens is there is, I'm trying to look for a word in English. The contraceptive methods will not allow the action of the antiretroviral drugs. So it's also a way of stopping them to act. So you understand if somebody is having an HIV, they should be able to suppress the viruses and reduce the viral load. So there is a contraindication specifically when they are taking a certain regimen. That's why when it comes to HIV positive client, you have to look and see which regimen they are using and compare it with the contraceptive methods that you want to give to the woman. If they are oral combined, you have to make sure that there is no contraindication in using both of them.
Okay. And then, Yvonne, I have some questions here that
yes,
I gathered from participants before. I have received a list of questions. So one question was related to the female condom. I guess maybe some may not have seen it. Practically, if someone needs a female condom, how does that go? How do you get it? Where?
So this is a barrier method. I think maybe when we finish about the hormonal method, I will respond to the female because I will also demonstrate it.
Okay, all right. Yeah, and
I have like an image that is showing the female condom. So when we will talk about condom, I will just demonstrate and answer the question.
Okay.
So I have a question.
Question only injectable. So yes.
I have a question about this contraceptive. There's a common problem for some women. For example, if you give birth for the first child and start using some kind of contraceptive just to at least to get pregnant, like after 2 years, some they are facing problems not getting pregnant again. What is that because the type of contraceptive they used, or is not because not compatible for their bodies? What are the main challenges of that?
Okay, it's not getting pregnant for the second time have so many underlying causes. We cannot just put a finger on them unless if the person comes for consultation. It doesn't mean that the woman who took contraception will never get pregnant because it was her first pregnancy. So she might have had maybe an hemorrhage post-delivery. She might be having other problems. She might be having even less ovum. Maybe that ovum that got fertilized was the only one that she was having. So we can't conclude that it's because of the contraception that she used, because it has been proven that contraceptives are not preventing the return of fertility. But if the person doesn't have a return to fertility within 2 years when she desires to have a baby, so they have to rule out other underlying causes, which are so many for the secondary infertility. So it's mostly the rumors goes to the contraception because she have used the contraception, but maybe she has other issues that are underlying that lack of the second pregnancy. So we can't just say that, oh, it's because that she used the contraception. I know it's commonly said in our community that when you use contraception after your first pregnancy, you cannot get a second baby. But if you look around, most women are having contraception and they get their second baby, third, fourth babies when they have already used contraception. So,
Hello.
should we proceed for the projection?
Can I ask question again?
I would suggest that we
Or
proceed and then
can you please write it so that can you write it in the chat box so that I can check it and we finish, because we just started and talked about pills only. Then we can answer the questions after, like, talking about all the hormonal methods. Thank you. So the injectable they are commonly in Rwanda, the ones that we're having, they are commonly Depo-Provera and also Net-N, which is on natural progesterone. Like it contains a synthetic progesterone, which looks like the hormonal progesterone that women are having. And in contrast, the monthly injectable contains both progesterone and estrogen. So some pharmacies in Kigali, they have the injectables that have both hormones, but the most common that we have is the Depo-Provera, that is 1 milliliter and is available everywhere. So how it works is the same as the way I have explained by suppressing the releasing of gonadotropin hormone. And also, it is now injected in intramuscular. So how effective this one is? About 4 pregnancies occur out of 100 women using progesterone-only injectables in the first year. So the return to fertility after injection are stopped in an average of 4 months longer for the Depo-Provera and 1 month longer for Net-N. With most of other methods, women can return to fertility in the next 4 months. So advantages, they do not require daily action. They can be stopped anytime. They are also good for spacing birth. So for the side effects and health benefits, the first 3 months, a woman can experience bleeding, prolonged bleeding at 1 year, and no more bleeding if required, sometimes of use. So mostly women consult us when they're having bleeding, when they're having a mood swing, but also the Depo-Provera causes some other side effects, which includes like vaginal dryness and also the loss of libido. When they come, I believe most of people here are Rwandan, but let's say, take a look, yeah. So most of the women, when they come, so they suppress really the libido and causes the vaginal dryness. Why that? The progesterone-only contraception, progesterone will go and work on the lining of the endometrium. So they causes the dryness of the vagina. There is no release of the cervical mucus to humidify the vagina. So when the vagina is not humid and there is no ovulation, which have been suppressed, it reduces the libido for the woman and also causes the dryness. So how to manage this? It's a common complaint when people are taking the Depo-Provera or they're taking also an implant. It's really common. And what we do is that we prescribe an estrogen cream that they put, or you give them combined oral contraceptive. So the estrogen cream is being used for like a week, 2 applications, and they're available in the pharmacy, while we prevent that vaginal dryness and we bring also the production of the cervical mucus. Then later, if you don't have access, because that the cream is very expensive, what you do, you can also prescribe the combined oral contraceptive, because you want that estrogen that is there to reduce the progesterone that is having, for the women, and make sure that you balance a little bit the progesterone levels with estrogen so that you can help the woman to regain again the humidification of her vagina, and also recover for the libido loss and increase a little bit of the libido. So mostly women also complain about weight gain, headache, dizziness, but the headache comes over the suppression of suppressing the action of suppressing the release of gonadotropin by stopping its release and anterior pituitary, and also the mood changes. Also, some studies have shown that contraceptive also can cause sort of depression because they are suppressing the release of all those hormones, but also the oxytocin level for women. And you know, the oxytocin is like a hormone for happiness. So it reduces also like the quantity of secretion. And scientists have seen that it can also, women under contraception can also develop like mood changes, and also the feeling of being a little bit distressed. So benefits, there are so many. Protect against the pregnancy, the cancer of lining of the uterus, and the uterine fibroids. May also help protect against the symptomatic pelvis inflammatory disease and the iron deficiency anemia for those who are not having menses. So for the people, sickle cell is not common here, but it reduces the sickle cell crisis among women with sickle cell anemia, and symptoms of endometriosis like pelvic pain, irregular bleeding, and others. The NET-N also helps protect against risk of pregnancy, of course, and iron deficiency because there is no heavy bleeding. So eligibility, people who are not having children, are married or not married, any age, and just had an abortion, smoking cigarette, but it's regardless the woman's age or number of cigarettes they're smoking, but also it also looks for women who are living with HIV, whether or not on antiretroviral therapy. So progesterone-only injectables can really be given to them. When to start? Here they're saying 7th day, but normally we say the 5th day of the menses, but it can also go up to 7 days because the woman is still safe and to use any contraceptive at this time. So when we talk about implant, I want to combine both of them so that we can have questions later. So for the implants, they are given under the skin, and mostly we put them on the biceps part, inner part of the biceps, but it can be put under the skin. We put here so that a woman can watch what is going on and really control, because we are also causing a low wound. She can also control for infections and other things, but it doesn't mean that it have to be there 100% because it functions by releasing the hormone under the skin. So there are small plastic rods. We have two types. We have Jadel. We have Jadel, which composed by levonorgestrel, are two rods for common in Rwanda. Our Sino implant is not system for 4 years. And the other common we have is Implanon, which has a etonogestrel, one rod system effective for 3 to 4 years. So the mechanism of action is still the same. So they work as the same as I said before. The primary mechanism increases the viscosity of the cervical mucus, making it harder for sperm to swing. And effects of the implant starts within 48 hours to 72. Inhibition of ovulation is mostly occurring in all the cycles. So the secondary mechanism is suppression of endometrial growth, so that it is less receptive to implantation in case there is but because it have stopped also the lining of the cervical mucus, the sperms cannot pass. So it's effective far less than one pregnancy per 100 women. So in the first year, which means 900 are safe for using this. So advantages are the same as the one we said for the Poprovera and others. So for long acting, you have seen that there is 5 years, like Implanon is 3 years, so it ranges between 3 to 5 years depending on what you use. So if you remove it, it's a return to fertility is immediate and have no effect on quality or quantity of breast milk. Therefore, it can be used in postpartum. So side effects are the same as the one that you could see in the Poprovera: headache, abdominal pain, weight change, acne, breast tenderness, dizziness, and mood change. But mostly also women present themselves having nausea. So the complication can come on the flexion of the sides when the woman gets like a big weight, increase the weight. So there will be always a problem to remove it because the woman have accumulated a lot of fats. And I think one of the rumor that are there is say that it's not easy to remove when somebody have already gained weight. But contrary to that, some women lose this weight when they are having the depot or they're having the implant used. So before we talk about intrauterine contraceptive device, I want to take like 4 questions regarding the implant and Implanon and the Poprovera part. Then I will talk a little bit, when I talk about intrauterine contraceptive device, I'll talk about the new device that we are giving right now, which is Mirena to women, which is an IUCD with hormone. So 5 questions, then we move on. Joseph had a question.
Yes. Okay. If anyone else has a question, Joseph as well, or maybe if you want to type in the chat, feel free to do that. Otherwise,
yeah, I can speak it now.
Yes, go ahead.
I was asking for this question. I heard from some women saying that they took the hormonal pills and they become big, they gain weight, and others say that after taking those contraceptive, they become smaller. And I'm asking, and I'm asking how the women can know the proper contraceptive method.
Okay, maybe one of the things I have to remind you that we don't do commonly because it's not a common thing we do, but when women find me in a private clinic where I can do hormonal dosage, I start by dosing their hormone. it's easy because you know now this woman have at this level of progesterone, this level of estrogen in her body. Then if I have to give her, I will give her this type of contraception and this type of contraception. But remember, contraception also have to be a choice of the person. So there is no like what is suitable, what is not suitable, because women have different bodies, different metabolism, different health statuses. So some gain weight, some loses weight, but this is something also we have to monitor first. So when a woman is taking contraception and gaining weight, it may be because of the progesterone, the contraception you are giving. But also after talking to women, sometimes I realize that because they are sure 100% that they are not going to get pregnant, they are relaxed. Some are eating in a way that is not healthy. So there is the role of the contraception itself, but also there is the role of the nutrition. So I've realized some women with Implanon, when I was asking, you gain weight and everything. So when you look at the lifestyle, because she knows she's free, she's okay, she cannot get pregnant, she eats in an unhealthy way. And then at the end of the day, she will say, oh, it's because of contraception. So you don't have to put like 100% the weight on contraception without ruling out other causes that can make her gaining weight. So I'm not denying that some gain weight. Of course, they gain weight because progesterone makes the process of metabolism go slow. So for some, and they will also cause in certain way. How can I explain? Let me see the way to explain to you. You see, during pregnancy, we are having the progesterone that is peaking to keep the pregnancy. And that progesterone causes the insulin resistance during pregnancy. That's why some women also develop DDM. So when it comes to contraception now, we are adding an addition of progesterone for that woman, even though she's not pregnant, but the level of progesterone you are giving her like slows the metabolism and later along helps her to resist on the insulin in a certain way, and she gains the weight. So the process in her eating and slow metabolism, and also the increase of the progesterone makes her gain.
We're sorry you could not join us.
So that is the explanation on why they get pregnancy, because most of the time they also come, they gain weight. So most of the time when they come complaining about gaining weight, remember there are so many women who are also complaining about bloating, like so that time, these women means that they're having a slow metabolism caused by the increase of the progesterone. So what normally we do is just reducing that hormones that we are giving her and put her on another contraception which doesn't have hormones. She can choose to go on IUD, which is not hormonal. Then also she can also use maybe condoms on another. So that's the explanation of gaining weight. So for losing weight now, it still can make her losing weight, but the explanation is still abstract, and scientists are yet to figure out why really the women lose weight when it comes to contraception use. So for the moment, the explanation that is out there is the gaining weight. And when you see that a woman is losing weight, you have to stop it immediately and make sure that you put her on non-hormonal contraceptives so that she can not end up getting unhealthy when all you want is her to be healthy. I hope you're satisfied with the answer. Any other question? before we move in?
We have one question in the chat. Someone is asking how some women using hormone methods
Hormones can get diabetes. I just explained it. They can, what happens, increase of progesterone makes also some women to get an insulin resistance, which means also when you get an insulin resistance, you are increasing like the low metabolism, but also you are increasing the fats and the weight is gained a lot. So, which means the woman is getting a lot of fats and is also exposed to diabetes, especially type 2, because of the weight she's having, the unhealthy she's getting. If she's eating unhealthy food, not to exercise and other things, she's at high risk really of getting diabetes type 2. So when you realize that a woman is gaining a lot of weight, you have to talk to her, not only by stopping the hormonal methods, but also making sure that you are talking about how to adopt a healthy lifestyle so that she can avoid to have diabetes. So there are so many studies that have been showing the relationship between the use of contraception, especially contraceptive, progesterone only contraceptive, and if a woman also have like a family history of diabetes and everything, and she's putting all the chances together, if I can say, call them chances, to have to develop a type 2 diabetes. So what you do is just stopping those hormones and make sure that you help reduce the weight. So
I think you can go ahead, maybe. What do you think?
Okay, so for the device, we all know the devices are IUDs, but the most common one is this one that is copper T, but we have different types. There is these ones, there are others that are non-hormonal, but the common thing they have together is this copper that they are having. So when they are in uterus, this is the normal size of the uterus normally. So when we put them inside the uterus, they are remaining like this. So what they do, they produce, this copper will provoke inflammation like for the endometrium to be thick, so that it prevents also the sperms to pass through and go to fertilize the egg that will be located here in the outer third of inner third, sorry, of the fallopian tubes. So they last for 10 to 12 years, and they're available everywhere in Rwanda. They are different. The common one is this copper T that is also in health centers, but in other health settings, like private health setting, but also private pharmacies, you may find that there are other types of IUDs. So this is a video you'll be able to see on your own when we share the PowerPoints. And oh, sorry. So for the IUDs, we commonly have them as a non-hormonal ones. But remember, like this one that is showing in this picture, this is Mirena, which has the hormone of progesterone, which works locally on the endometrium and make it thick so that the sperms cannot pass. So the copper we talked about, there's copper sleeves, there's as you can see here, and we have also copper wire and the steam, and also we have the arm for the copper IUD and different depending on the country you are, but commonly we have the chemical changes interfere with the ability of sperm to reach the ovum body, a sterile inflammatory reaction, the implantation. So for the benefits of the IUD, we have all effective on 99% long-term, like 12 years, then do not require ongoing effort, effective immediately after insertion. They are cost-effective and fast return to fertility because they are not hormonal. So they don't interfere with breastfeeding, but also can be used by anybody as long as they wish. So the disadvantage is that it doesn't protect against the HIV like other contraceptive except condom. So complication, they can cause uterine infection. They cannot also cause other problems like heavy bleeding, and that's what we see when women are cancer. So menstrual irregularity, as I was saying, it can also, if it's put by somebody who's not experienced, they can cause perforation. So any age, any parity, they can be using as long as you rule out all the contraindications such as STIs and others. So the types I've showed you, the copper is 12 years and Mirena is 5 years. So the patch are also some other contraceptives that we use, but it's not common in Rwanda. I wanted to talk a little bit on condoms. We have male condoms and female condoms. These are the only condoms that, contraception that protects against STIs and HIV. So we have them, the male condom. These are videos that you can watch, but also they are robust and they can be used by male, the male condoms, as I showed you. They are effective and can be used by everybody. And when used properly, so they protect against HIV and STIs and other, and also pregnancy. But sometimes it happens that when they are not well used, they can cause also, they can rupture and cause other, like a female to get pregnant. So people are having, using the condoms, they make a choice of protecting themselves against diseases and also against pregnancy. So for the female condoms, these are the condoms we are having, but I'm not sure that they are commonly used. But if you go to the health center, you may find one or two. If you go to private pharmacies, I'm not quite sure because I have been asking like 10 pharmacists in Kigali, and they told me there's no female condom in pharmacies. But they look like this, and they are used by females. And this is a video you can watch later. So they are easy to use when taught how to use them. They work also as a barrier to stop the sperms entering the uterus, but also protect against HIV and other STIs. The effectiveness, they are not quite effective because they about 21 pregnancies occur out of 100 women using female condoms the first year. So why some women say they like female condoms? Women can initiate their use. They are soft. They protect. Why men say they like female condoms? Because they can be inserted ahead of time, do not interrupt sex. They are not tight for them. So it's easy for them to just having a female partner using them. So the side effects, mostly, unless if somebody is allergic to rubber, that's one of the things that can cause side effects. So here we have useful links, as I've been saying. You can have them and watch different videos, and you can also go through all these references that I have been sharing. If there is any question, you can reach out to me and Health-Edu and ask more questions about contraceptive. I'm sure we did not go through all of them because of limited time, but I managed to talk about the most common ones that we are having in Rwanda. So the floor is yours. You have the right to ask questions for the next 13 minutes.
Most minutes. If anyone has a question, feel free to raise your hand or type it in the chat. Yeah. Maybe Yvonne, there is a question about emergency contraceptive. When are they used in terms of time, and suggest some types like names, just practically, like if it happens that someone needs them, what is the right time to use them, where to find them, and what are the sample like types of them, the products that can be used?
Come again?
I was asking, there's a question here, emergency contraceptives, when are they used in terms of time? This is kind of like whenever they need, yeah.
Okay, for emergency contraceptive, it's normally being used within the first 72 hours, because that's how, when their effectiveness is reaching at least at 95% of its use. So it can, some people say it can go up to 5, but it depends on the monthly period that person is. So it's not something that is static. It depends on the situation. If the person is having in the first week, second week, or the third week of the menstruation cycle. So mainly we encourage people to use them within the first 72 hours for increasing their effectiveness.
Okay. Great. Do we have any other question?
I have
in the
one
chat?
question.
Go ahead.
There's a myth saying if you keep using more, there's emergency contraceptive method, there is a risk of becoming infertility. Is that true?
Pardon me?
There is a myth saying if you keep using many emergency contraceptive, you are losing a chance of getting pregnant. Is that true?
It doesn't have anything to do with pregnancy. The emergency contraceptive will stop the sperms to fertilize the egg, the ovum. So pregnancy to take place, there have to be the meeting of the sperm and the ovum. So if what the emergency contraceptive does is just to stop it. And for that moment, so
is that an internet issue?
it's fine. Like, it doesn't have to do anything. So what I want to add also is the emergency contraceptive is after unprotected sex or ruptured condom that people were using. So it can happen. So somebody's asking if the emergency pills works during ovulation. So it can, because it can also make sure that there is no implantation by thickening the cervical, the endometrium, so that there is no implantation.
So my question was about if you keep using many times, for example, if you use those emergency contraceptive every month, it means you're losing a chance of getting pregnant.
Every month, when you see somebody who is using them every month, we encourage them to use like other contraceptives, not to keep using emergency contraceptive. Yeah.
Great. So, and then in the audience here, I can see some people. Do we have anyone who have used a female condom who can tell us what was the experience? Anyone? Anyone?
Or counseling somebody who is using them or providing them, because they may not have been using them and don't come with them, but if anyone can share the experience. But meanwhile, when they are thinking about it, somebody asked about what can we do when somebody is experiencing heavy bleeding using IUDs and has contraindication on hormonal method. This is a tricky situation. It happens most of the time that somebody may experience the heavy bleeding while the body is taking the IUDs as a foreign body. So you have to see how severe that bleeding is, because for myself, I've already encountered like 4 clients who are having heavy bleeding, and it was severe up to the level that they were having very like anemia. They were starting being dizzy and stuff. So I preferred to remove it and make sure that they are stable first. And when we tried it for the second time, I realized that her body is rejecting. So mainly, if you provide ibuprofen, you know, it's NCIDs, is it will make the IUD, the copper part of it, not to do its work as causing like inflammation, like, because you know, most of the person that are giving NCIDs for these women for the pain, but also for reducing, is the NCIDs is that inflammation. It's an anti-inflammatory. So when you give it, it will not make the IUDs function. And mostly because we give a high quantity, like 400 to 600 milligram, even 800 milligram of ibuprofen, you end up causing the ineffectiveness of that IUD. So for me, I prefer to just remove it, treat the patient, and make sure that she's not having that heavy bleeding, and also to quantify that heaviness, because sometimes somebody will say it's heavy, but how many times did they change, and the hemoglobin is like what? So be careful when you are also providing the NCIDs such as ibuprofen, because you are making sure that these IUDs are not going to function. So look at the bleeding and make sure that she's not anemic, and if the body is rejecting it, so you don't have any other solution than counseling her to use a condom and make sure that when the partner is participating.
Right. Thank you very much.
I don't understand if you understand the mechanism of action.
Come again?
So Midena can be recommended to diabetic client. Midena
can be recommended to diabetic clients.
It still depends on the situation, because if you have a diabetic patient that is not controlling her diabetes, it's really difficult to counsel that person. But if somebody keeps glycated hemoglobin under 6 and she's exercising and eating well, and she's not gaining weight when she's under the Midena, so it depends on the situation. So diabetes is not a contraindication of using those contraceptives, but you have to look at the way the person is. Glycated hemoglobin and fasting, you look at the blood sugar and the fasting level, then you look at her weight, but also the lifestyle that she's having. So far, I've seen some women being recommended to take them, but when they are
okay, now we have another one. Now we have another question down here. Some women, there are women who use emergency pills in 2 hours after sex, but get pregnant. How much are these pills effective? You are on mute.
Muted.
You are on mute. Hey, Yvonne, you are mute. Okay.
So women with the failure of emergency contraceptive is even the failure for other contraceptive methods. What happens is this: does that woman level of progesterone at a normal level? Because some are having low progesterone. So when you're adding this emergency contraceptive, they are just elevating a little bit the high level of progesterone, and then she gets pregnant because it reaches at the level that the body needs now for the pregnancy. So most of the time, we don't know the level of our progesterone. So when you
How can we know that? How can we know that in the community? Like we are in the village somewhere.
It's just a checkup for hormonal dosage. There's nothing
And
else.
it can be done at the health center.
No, it's done at specifically at the hospital, but not all the hospital. I think teaching hospitals and private hospitals. So that's also the effectiveness of all this period, of this contraception. So we need to know the level of because it's an addition of the progesterone that people are already having in their lives. So if their body, they don't have enough progesterone, so of course it is going to fail. But also there are people who are not taking the right dose, like using the emergency contraceptive using microgynon. So you find that they did not calculate well the quantity of progesterone that they're supposed to take immediately after having unprotected sex. So it requires to know, even though they take 2 hours later, what did they take? Even though they take 2 hours later, how are the level of the progesterone? Because even some take Depo-Provera, they get pregnant, and when you realize that they have low progesterone, and when we added the Depo-Provera, it was just increasing their level of progesterone, which makes the pregnancy to be stable.
So I have another
Right.
question. While you are talking about contraceptive method, you are more concerned about women. How about men? Are you not supposed to get the contraceptive method as well?
The men are supposed to use condom.
Only?
So that's
And
the
if,
only one. Unfortunately, up to now.
If you don't want, Yvonne, if you don't want to use condom, what can be done?
You don't want to use condom. So there is a way of doing the withdrawal. But is it effective? Is it possible? And so far I've been asking some people who say that they can use the withdrawal method, but I'm not sure, because most of them, recently I was conducting a research, and some people in a focus group discussion, some men told me withdrawal ningo gusimbuka ikamyo irimo kumanuka ishyorongi idapaki, which means it's not possible. Yes.
Is it impossible? Maybe other people here can tell us, but no one in the chat.
No, midwives. I can see there are a lot of midwives. Is it possible? There are a lot of men. Is it possible?
No, all of them has muted now. The microphones are not working. Okay, Emmanuel, tell us. Emmanuel Turi Kumana. Oh, maybe unmuted. Okay, Emmanuel, you want to say something? Anyone else? Great. We're actually at the end of this session. This is 4:31. Thank you very much, Yvonne, for the time to prepare, time to engage in this kind of audience. We've received more than 71 people attending, and this is something that we're going to do several times. We appreciate the time that you took to prepare the slides, but also the time to present for the whole audience. If someone needs a certificate, you're welcome. If someone needs a certificate, there's a link shared, or they can use
I'm sharing because I'm seeing most of them coming from the University of Rwanda.
Okay, so you can share that link.
I'm going to share with them.
Great. All right. Thank you very much. Thank you for coming, and we see each other next time.
Thank you. Bye.
Bye-bye.